Hello, welcome to another episode of Essential Implementation. Today, I interview 4 doctors about their experiences of implementation in the health service. At the Improvement Academy, we often invite practitioners such as these to come and work with us and do research with us. And it's people like this, doctors, nurses, occupational therapists, physios, anybody like with that sort of expertise who don't always get a voice when it comes to implementation. The sort of studies we do, the data we collect, the outcomes we aim for, always mostly driven by academics. I recommend listening to this interview right to the end. It's fascinating to get the first-hand experiences of 4 doctors who've been working on the ground for many years, to get their experiences of implementation, what helps, what doesn't. We covered a lot of things: learning systems, de-implementation. We talked a lot about fear, brave leaders, doing what's right. And also, we did touch on COVID. I think that was such a fascinating time for learning about implementation, and also, doctors being part of research and what they appreciate from researchers. Enjoy.
I think maybe to start with, it would be great just to go around and briefly introduce yourselves and what you actually do.
Yeah, so I'm Shireen. I'm an obs and gynae registrar, and I've worked in Yorkshire doing obstetrics and gynecology for the past 10 years.
Hi, I'm Lizzie. I'm a GP trainee and have been for 4.5 years now, so nearing the end of my training.
Hi, I'm Amanda Stone. I'm basically Shireen, really, apart from I haven't worked in obs and gynae for 10 years, but 7. And basically exactly the same.
My name's Kieran. I'm an emergency medicine trainee.
So we've got a lot of different experiences here today, and I've studied implementation for a while, but I'm really interested in getting what your experiences have been. Is anyone feeling brave?
Go on, I'll go first. So and it does actually fit along the work that I now do, so it was quite interesting. So a few years ago, we tried to bring in deferred cord clamping or delayed cord clamping. So when the babies are first born, waiting a minute before you clamp the cord, because the baby gets an extra blood transfusion from the placenta, and it can improve outcomes of the babies. And it was, I don't know, maybe 6 or 7 years ago when I was in Bradford, we'd started to do this. And there were lots of challenges when it first came in. People saying, well, what happens if the baby's born and it needs resuscitation? And we would normally clamp the cord and pass them over immediately. And so that was being implemented. And I do remember the consultant sort of running down the corridors, almost stopping you, don't clamp that cord. And it was that person being there all the time, coming around every day saying, are you doing this? Do you know about this? And I think that's why that worked, because there was that one champion for it who was there, who was reminding everybody. And it was fear. It was the fear of him coming and saying, why haven't you done it? Or him running into the room saying, don't clamp that cord. And I think that's what made it, that one for me, the most memorable of all of the implementation or all of the improvements that I remember.
That's a very interesting example. And I imagine, is it now sort of commonplace for this to happen there, or has it been?
Yes, it is much more commonplace now.
Great. Does anyone else have an implementation story?
I can say mine. I remember I'd worked in a department for over a year, and which, because we rotate, you really felt like you're part of the furniture if you're there for over a year, because it's normally a year maximum until you move. And one day I walked into the handover, and the handover process had all changed. And I remember thinking, this is a major part of my day, and why did I not know about this? And because I felt that way, I probably immediately looked at it, the changes, in a more negative light. They then said, oh, well, it's just a trial. And I was like, well, how are you getting feedback, and who are you getting feedback from? Because despite feeling part of this department, part of this team, none of the other junior doctors were involved in any of this. And it didn't seem, when I asked, well, how will we feedback? It didn't seem that our feedback was wanted or being sought at all. And after a while, we all got used to this new process. It remained in place. And it did leave me thinking, these things just kind of, it's top down. And maybe they did consult some juniors, but that wasn't vocalized to anybody. And it made me think, well, maybe I'm not really part of this, because these things just happen. And it's a handover. It's getting people's opinions who are part of the handover every day would have been important. It's not like based on, say, some research of a new medication or any that is kind of more detached. The handover everybody attends and everybody's thoughts should be valued. So I remember thinking, oh, getting a bit fed up, and yeah.
Oh, thanks for such an honest, description of your experience. I mean, a lot of research does tell us that the more involved teams are in the intervention, if they feel they've had a key part in that, and if they can make it their own, the better implementation will be. And I mean, it depends on the intervention. It's true, some interventions will be implemented well if it's top down, but bottom up can also be a really great way to get something in place and to sustain it over time. And so, yeah, I can imagine it must have felt quite strange to go in somewhere that you work and not feel that there was much communication or engagement about it, or so you could prepare at least. And again, feedback, that's really important. If we're implementing anything with a team, we do need to be getting constant feedback to find out how it's going and if it's working, if it's being implemented well. And that's a key approach that we now take at the Improvement Academy, is to do that. Why wait, 1 or 2, 3 years to find out something isn't working? Why don't you find out in a week, right?
I think sometimes there is kind of a want to involve the frontline staff in this scenario, but the frontline staff stopped at a senior level, the coordinators. It didn't reach any further down, and that's kind of, I think, a false pretense. Like, yeah, we've involved like the people who are involved in their handover every day. No, you haven't. You involved one person, a more senior person, nobody else.
Playing devil's advocate, why do you think that might be? Is it a sort of a cultural thing, or a capacity thing, or like?
Probably a bit of both, but
Yeah.
I think sometimes what's lost is the benefits that us as junior doctors and more other junior members of the team who rotate around different hospitals, we have a wealth of knowledge about what we've seen in different places and what we think works well and what we think doesn't work well, and that's just lost from that approach, which is a shame, because we do, I think, have a lot to give.
I couldn't agree with you more. I tell people all the time that the teams, the people in these settings, are the experts of their setting more than anybody else. And so involving them and their knowledge can be a lot more effective to actually implement things that matter to people and that they feel they actually need. We're not really clever enough to know what the impact of that will be. If we get every single ICU ward to do exactly this thing, well, every single ICU ward's different, with different needs at any one time. So I'm aware, Lizzie and Kieran, is there any stories you would like to share?
I think I'm kind of more on Amanda's viewpoint. I think when you asked me there, Christian, to share, an example of a positive implementation that I've been a part of, one didn't spring to mind. I just thought of maybe the multiple unsuccessful things that have tried to be implemented over time. I was reading a paper earlier on in the week, and it suggested about implementation that, we should email more people to get the message out. And I can, Shireen mentioned that she didn't know whether she read their emails. It was more that someone physically there helped make change and implement a new process. And my reflection would be 100% that real human connection and relationship. That is something that enables implementation, and having a visible leader that's championing something. And that's where success is made with implementation, from my point of view.
Brilliant point. Having a formally appointed implementation leader, somebody who can make decisions, is vital. And I agree also that sort of engagement, go and get to know the people that are going to be doing the implementation, gain their trust, ask them what their thoughts are, what their needs are, use their knowledge and try as best as possible to get them on board. And it might be that they're not ready, that they don't have the motivation for a good reason, if there's other things, or they don't have the capacity because they're so overstretched and they might need something else. Kieran, is there anything you'd like to add?
I echo sort of Lizzie in that it was, sadly, couldn't think of many positive interventions I'd sort of been involved in. I think what you were saying there about what matters to people was quite important. And last year we tried to implement a kind of standardized checklist for cardiac arrest documentation. And somebody else had designed this project and I became involved in it. And there was lots of enthusiasm from the resus team, of course, because it would have helped with their audit process, and the resus lead because it followed all of the resus evidence guidelines. But we had real trouble getting people to use it. And I think the reason for that was because it doesn't really matter to clinicians. You know, there's so many checklists or documentation performers that had been tried for so many things in the past, and it's sort of death by performers, and people just weren't really interested in another additional standardization that really probably wasn't going to affect the way that they practiced in those situations, though it may have improved some data collection after the situation. So I think it's that thing of having people, designing something that people have a stake in and people want, rather than and we probably didn't involve those people enough in that. What did they want, or what problems were they having with cardiac arrests?
Wow, what a brilliant example. I'm not surprised that it's difficult, because implementation is really difficult and it's very messy. I mean, we've got to keep trying, right? Because people can't benefit from what they don't receive. But I'm just wondering if you have any thoughts about how we could maybe get better implementation outcomes. I mean, you've mentioned some of these things that might facilitate it, things that are clearly an issue. But if we go a bit deeper than that, and I'm thinking more of like learning health systems, this idea that maybe you can have a constant kind of learning process going on in a setting where people are actually given the power to do what they feel they need to do. Do you think that could be a way forward? And do you think, if it is, would that even be possible?
So I think it could be a solution, but I think all four of us as junior doctors come from a specific point of view in that we're rotational staff. So as Amanda says, we can be on wards or placements for only 4 months. So it's very rare that we're somewhere for longer than a year. So in order to build those relationships, to be part of a learning system, from a junior doctor point of view, that's really difficult for us to be able to implement change. It's more the constant substantive members of staff that are the ones that are able to do that.
And I think, building on that, kind of asking us to, in those 6 months, to figure out a problem we want to address, building those relationships in order to address it, and then finding a solution to it. We're pushed to create a sort of short-term positive outcome that we can say we did something. So for 2 weeks, these metrics improved. And then what you find is it's a totally unsustained outcome, and drops off, 6 months down the line has completely dropped off, and you've not had a sustainable intervention. But we pat ourselves on the back because that's what we want, or we're expected to do for our kind of CV purposes, and people want to prove that they've done something. And it's often quite artificial, I think, the improvements that are created and not sustained. And I think it's a balance between giving people the freedom to approach the things that they want to address, or the perceived problems, so that they can have a bottom-up approach, with actually facilitating that with departmental problems that need to be addressed and are going to be sustained over time, and priorities, I suppose.
Maybe there's a sweet spot between perhaps what's needed sort of bureaucratically and with budgets and things, but then also how much autonomy and freedom people are given on the ground.
I think that comes down to sharing information with staff. There's often managerial teams who probably know what the data is showing, where the problems are, but actually if you ask the staff kind of on the ground where are the departmental pressures or problems, they may not know, and it's not always shared, the kind of safety problems or problems that need to be learned from.
Yeah, obviously the NHS and our trusts are under a lot of pressure. I mean, do you think that's part of the issue as well, that people don't have time for these discussions and these meetings don't happen?
I think that is part of it, but I don't think people value that time to see that, those discussions could actually in the longer term make a better work environment and a better culture for these things to happen. So I don't think it's purely the time. I think it's people in those positions having, the headspace to be able to think, actually, no, a meeting to discuss this now face to face would negate a lot of problems further down the line.
Yeah. So if you were suddenly given this new role, you get to decide how implementation happens and how decisions are made, and what would you do in that situation?
Are there more hours in the day?
More staff?
Yes.
I think that it almost the NHS almost needs a pause and a reset and a rethink, because currently we're just fighting the next battle or the next challenge or the next 20 patients in clinic, and you can't give that dedication then to it without saying, well, that 10 patients aren't going to have an appointment now if you stop and give your time to implementations. And so it's really tricky, and I don't have the answer, and I don't know the answer, because clearly if you actually gave the time to improve outcomes and measures, you might then have less patients, and therefore, you know, in 10 years now down the line, you might not have as many people coming to clinic. But it's, how do you do it now when everything is just so tight with time, staffing, money? It's just a huge challenge, and I don't have the answer.
And I think some of that might come from drawing people together to focus on and support people to focus on what works and, you know, what is shown to work, and then, you know, provide support to implement something as a team, rather than lots of individuals kind of trying to implement several different things all at once, which may or may not be effective. And I suppose it comes down to what I said before about death by performers and adding extra stuff in when actually it's not actually adding a huge amount of value. And is that just, you know, creating a kind of messy environment where you don't know what's important and what isn't? Yeah,
I'm very aware, and actually every time we ask teams to implement something, we're just adding to their workload. Any time away from the patient is also often frowned upon by the media, and politically it's not that easy to do, is it? I mean, we've been focusing a bit more on de-implementation, which again could add to workload initially, but the outcomes are different, because you're decreasing something that's low value, or replacing it, or even getting rid of something altogether. A bit like Shireen, you were saying, a reset, stop and reset. Well, maybe it's time now, instead of implementing more and more and trying to get better outcomes, is to actually start removing things that we don't need or people don't feel are actually helping. So there's more space and time to then implement the things that really matter. Is that just a blue kind of naive view, or do you think that's something we could perhaps do?
No, you're speaking my language. I think anything that's just adding in processes, especially processes that may not be necessary, is just a waste of time and resources at the moment. And we really have to focus on the limited resources, human resources we have in hospitals to be you know, taking on extra processes, unless they're really proving to be adding value to patient care.
Yeah,
I think though that one of the reasons why there is so much that probably needs to be de-implemented is because that sometimes things, I feel, seem to come about because of a knee-jerk reaction. This happens, oh my gosh, we now need to do this. There's another form. And over time, you have a wad of forms that all need to be filled out, for example. And yet there's a fear that if we stripped 50% of them and this problem happened again, that it's because this form wasn't there. And then because of that fear, we're going to put all the forms back in. Then we're going to have another form to make sure that we've got all of the forms. And then it's like this negative cycle. So I think until we feel that we would kind of still be protected, still be like experienced, be valued, that we could have more autonomy, I think the way things are in the NHS, that removing things sounds great, but in practice would be quite difficult.
Yeah.
Although it's difficult, I still think it has to be done.
Yeah, definitely.
Because there just isn't the space or time or staffing for more improvements at the moment. And there won't be unless we stop doing some of this low value stuff that isn't affecting patient outcomes, isn't improving patient safety. We've just become reliant on a piece of paper that actually means nothing. And there are lots of pieces of paper that mean nothing. And I think it's more so for the nursing staff than for us.
Yeah,
I think
definitely.
they are filling out the majority of these pieces of paper that may never get looked at. They may be filled out, but they're never ever, or they only get looked at in the event of, which might happen once in 1,000 patients or something. And then yes, you've got that protection, but is that really necessary? Is that 1 in 1,000 patient that then did get a pressure ulcer? You know, I think there's more for nursing staff that could be implemented. I was trying to think of examples before today of what we could de-implement, and I have to say I was struggling a little bit.
I think as well, with the de-implementation, like you said, low value, that's all subjective as well though, because if you are that one person who, okay, well, we've de-implemented that, I'm no longer doing that. And then there is a complication for that patient you're looking after, then you might not have trust in the system that you're going to be okay. And I find, to say, in midwifery, the notes that midwives make are very contemporaneous about every last aspect of what has happened. Answered the call bell, introduced myself, made them a beverage, every last thing that I could not comprehend writing. But I see why midwives do that. It's really shouldn't be necessary to document every last second of interaction. But I think there is a degree of needing or wanting or feeling that you have to protect yourself. And if I were in that situation, I probably would be writing everything as well. And yeah, it's a sad state to be in, but I can't see it changing.
I'm getting a sense that there's a lot of fear within the NHS and within our healthcare system. So people are afraid. Yeah.
Definitely.
I suppose if people are afraid, they're less likely to perhaps take, I don't know if it's the risk is the right word, but sort of perhaps do things outside of the box, try something new. I've sort of studied quite a few different contexts, schools as well as healthcare hospitals. And, you know, it's the brave leaders, these sort of, I remember this head teacher that I knew that was just really brave. Like, she was like, no, I'm just going to, I think this is right and I'm going to do it. And like, it was the opposite to what a lot of other schools were doing, but she did get better outcomes. So I think there's something about people being brave. And I suppose to be brave, it's easy to be brave when you know your back's covered, you've got support, isn't it? And if you feel you don't.
And I think we've talked a lot just now about patient kind of involvement in terms of de-implementation, but thinking about the wider workplace. So I was talking about how in COVID and because of COVID, and especially in general practice, a lot of things were lost that wouldn't have been seen to add value to, you know, the patient interaction. So staff meetings, staff social events, you know, morning coffee with the team, that was all lost because of infection control guidance. And that hasn't returned in some places. And actually, it's really hard to quantify how much a difference it makes to the patient outcomes, but the staff well-being and staff experience, a lot of that has been lost as a result of things being de-implemented because they've been perceived as being low value.
Yeah, I've been very shocked actually. Yeah, about some of the things I've heard. I mean, I think this knee-jerk reacting, as you were saying, and this fear, and also the political aspect of things, that is never that helpful, I don't think. So I was speaking to an exec on the podcast, and a while ago, but I'd found out, I think somebody told me in the Improvement Academy, but the seating was taken away in the staff room. So people wearing PPE for 5-6 hours, sweating, and then they go and take their 20-minute break, and there's nowhere to sit. And I'm like, we understand you need to control infection control, but realistically, is it going to make that much difference? And even if it is, realistically, what's the cost of that? I mean, we just can't afford to do this anymore. You know, we need to understand these systems better, understand what's actually going on, understand what the people are feeling, going through, before we just make these sweeping, decisions. We need to look like we're doing the right thing, so we're just going to get rid of all the seating. We can't afford to be this unempathetic to these systems, because people are now leaving in their droves. 40,000 nurses in the last year alone. We haven't got a choice anymore. We haven't got the privilege doing the right thing politically so we look good. We can't afford to do that anymore. We just need to do what's right.
And I think yeah, I fully agree. And I think there's probably, when you're talking about, things that are difficult to measure, is what Lizzie's talking about, like staff experience and those conversations and things. And I don't think because what we tend to do when there's a problem is we want to try and improve it. So we try and find a metric that we can easily measure, and we can say, oh, great, we've got 98% people have filled in the proforma, which says that they've thought about pressure ulcers. But actually, maybe you're missing 2 or 3 whys as to why actually people aren't. And it might be that staff just aren't feeling capable enough and having the time in the day to be able to check patients properly, and you're missing that kind of why. And I wonder if that's more into a kind of more difficult to measure, staff experience of the day part, rather than, but we tend to like things that are easy to measure and therefore easy to prove improvement in, I think.
Yes. I do have some. I mean, I always think behavior change is a bit like that as well, because it's like, oh, we just need to change this behavior, and then that will fix the problem. But that's sort of assuming that we know what's best. When I like to empower the team to decide what to do, and not try to change their behavior. And so, yeah, so I think that's also like kind of relate to what you were saying. It's simple, but it doesn't really capture the complexity of the situation. Amanda, were you going to come in there?
Yeah, well, I was just going to say about the kind of people's thoughts about what teams need and what they actually need being mismatched. For me, I'm really sick and tired of little gifts. I don't need any more little gifts. I don't want any more little gifts, particularly in this current environmental catastrophe. I don't need another tote bag or a water bottle or anything like that. And I think that's like so much time and effort and money is put into these things. Unless it's a pen, I will happily take a pen. I think that is the most useful gift. But you walk into a ward and there'll be in the staff like a little box where you're supposed to put £1 a week for tea bags. And in the cupboard, there'll be loads of milk that's just for patients, no milk for staff. I just think, what do we do when we go to work? We have our breaks. We might make a cup of tea, make these things easier for people. I mean, we don't need 5 different people bringing in 5 different milks, and then there's an argument of who's put the money in the thing, who's paid the milk. No, that's patient's milk. You shouldn't have taken. Whereas that could be so easily solved rather than plowing money into tote bags that you're going to give to your staff. And I think staff on the ground would easily say that would make more difference, most likely, or be a nice thing. But the people who sometimes I think making these changes are not kind of consulting with the people on the ground. And I feel really bad sometimes thinking that way, because there's positive and nice thoughts gone into these things. But if anything, like you said earlier, some things can be like a slap in the face. Sometimes that's how they come across more.
Yeah, a good example of a mismatch between what staff want and sort of managerial positions want is they thought it was very important at one of the hospitals I worked in to have the managerial staff and the matrons offices on the ward, because it would create a better communication and relationships between the staff and management, which seems like a great idea. But to facilitate that, they took away the staff restroom and turned it into an office. So the staff had no comfortable seating to have their lunch, which you can tell which one was the priority of the staff.
That's really bad too, because a lot of I did some work on an ICU ward last Christmas, and the staff room was the place where a lot of implementation happened. Those conversations,
Yeah. And interesting, I know the ICU talking about it was a very, all the different staff members spoke to each other.
Yeah.
Those kind of, that coffee in the morning was actually a really important time to kind of set the framework for the day and what was going to happen that day, and establish training priorities for trainees. Like, it seemed like everyone was just sat around drinking coffee, but it was actually quite an important time.
Lizzie, were you going to come in before?
Yeah, it was just on what Amanda was saying. So, and a positive reflection in terms of leadership and how they were a consultant in the department I worked at, in an emergency department, had been told by some senior leaders that they needed to get rid of the coffee and tea trolley for staff in the emergency department because of infection control reasons. And this leader was actually quite brave and said, we're not doing that because that's the one thing we can do for our staff. We can make sure that they're well hydrated on shift. And I just valued that leader so much more for noticing that was something that was important to staff. It really made my day when the housekeeper came around and made my cup of tea just how I liked it. It wasn't much, and it wasn't, a particularly nice cup of tea, but that kind of interaction between the team members and just being allowed to drink your cup of tea and recognize that you're a person who needs to drink and be well hydrated in order to work. That made a massive difference to kind of my whole experience on that 6-month rotation.
I can't imagine what it would be like, how I'd feel if I went into work and they'd taken away the drinks trolley, or the staff room, or the seating, and then gave me a drinks bottle and a badge. to say be nice. What's going on? I mean, I do think that the obviously the pandemic was very difficult for a lot of people, and I think we did some things that perhaps weren't very clever. Maybe there's some, and that's back to the fear. But surely we can do a bit better. Kieran, did you want to come in there?
It was just a further rant about drinks bottles and PPE in the pandemic, but it's probably not going to add anything.
I think we did some silly thing, obviously some very silly thing in hindsight, but also, for our staff, but also our patients, not allowing women to have their birth partners with them. And, we did some terrible, and I think it was the knee-jerk reaction. And at the time, I kind of felt it was okay. It's only in hindsight now when you realize how much that really did affect people, you're like, that really wasn't the right thing to do. But at the time, we were also scared of catching COVID, and we were scared that if there were more people in that room, your risk was higher, and we didn't know what the right thing to do was at that time. But yeah, looking back at it now in hindsight, there's some really bad things that we did to staff and to patients as well, and that's quite sad, quite difficult to deal with.
It's almost like, then there was this single unifying priority. So anything that would improve that priority, you would just get behind, because that was the only thing we were worried about. Whereas now we've just got a complex mix of problems, and it's kind of down to leadership to balance those out. And of course, infection control are going to want to not have the tea trolley, but actually it's up to leadership to balance those priorities and say, actually, some of these things other things are important as well.
Yeah, I can't help but think about the cancer backlog and things like that, because again, I understand why those decisions were made, but now we're really, I think, paying a big price for that.
And interestingly, you can't have your tea trolley, but you can all go and do yoga together.
Very strange.
They're contradictory as well, aren't they? And
yes,
I think COVID showed us sometimes that we were too slow to de-implement stuff, because like Shireen said, we did not know what we were facing during COVID. So I understand why we did a lot of what we did, but over a short period of time, really, in the grand scheme of things, we realized we knew a bit more, we gathered information, and we didn't change our practice very quickly. I don't think. We still continued with crazy restrictions to visiting and people coming, and we were despite being very quick to implement these things, we were so slow to de-implement them in the face of very rapidly emerging evidence that actually that wasn't needed. And that was really sad, because we showed we had the capabilities of doing all this stuff really quickly, and we should be able to just as quickly reverse some of these things, but we didn't. We kind of went back to a slow pace of doing things like we did prior to the pandemic, despite kind of being aware of the very negative potential impacts of what we were doing.
That comes back to your previous point, Amanda, about fear. There was probably a fear of de-implementing things in case there was a problem.
Yeah, I don't know. Is there any other points people want to make? I mean, I feel like we've had a really good discussion.
I have one thing. I feel I've been very negative, so I have a positive experience I just want to mention.
Yeah.
Just about engagement. So in Bradford, there's a lot of research, and when you join the department, they encourage you to do your GCP training and get involved with the research. There's a very welcoming and present research team. And I remember being involved, recruiting some patients for a trial with regards to giving antibiotics or not when they have an instrumental delivery. And I loved it. It was my first proper taste of being involved in research. And then a few years later, when these changes come about, I was so on board. And I know that can't happen all the time, and I shouldn't have to be involved with research to want to implement these changes. But it really did show, like, I was championing this. I was going, you didn't need, send me an email about it. I'm going to be happy. I'm going to read. I'm going to talk to people about it. And it showed me how much, if you get myself, but other staff members, I'm sure, on board, you can make things happen so much quicker, easier. It's going to be more sustained, I think, anyway, from my experience. So yeah, that was a very positive implementation.
I think engagement is absolutely vital. I think it's probably more important than your implementation strategy or your, approach. So it is, and me and many others try really hard to engage and create rapport with people and actually listen to them. Is there anything that you would really appreciate from, say, a research team?
So I think I would really appreciate, like you say, Christine, that human connection. So meeting you face to face, and sometimes, especially I'm thinking in terms of implementation research, just the opportunity to facilitate discussions between team members, so that you're not necessarily doing the research yourself, but you're allowing the space for the conversations to happen. And solutions to come about from the teams themselves. So that kind of facilitation, I think, is what I would want from implementation researchers.
Yeah, I think it's similar, isn't it? It's the fact that that you respect our thoughts, views, opinions, that we do know something about our workplace, and by being involved, as Amanda said, if you're involved in the early stages, you're more likely then to want it to work and to try harder to make it work, even when time is limited. So it's being involved, isn't it? Knowing it's happening before, I guess, knowing it's going to happen, knowing what's going to happen, and what part we can play in that.
Thank you. Yeah. Well, I suppose very final thing. Have you got any thoughts about what you might do going forward, or in terms of implementation, if you're in that situation again, or would you do anything differently?
I think, Christian, so. After my clinical leadership fellow year, I went back into clinical practice, and as Kieran says, we have to do quality improvement projects each year. And the thing I took from my year working in improvement and listening to improvement and implementation experts was speaking to people, involving people. So I noticed in my practice that I went to, change just happened top down, and it was expected to be implemented, and it didn't work. So I went out, and spoke to the receptionists, spoke to the healthcare assistants, asking them what they thought of the existing process to enable me to come up with a process that worked better for them in the future, rather than just adding another thing for them to do and expecting them to do. And that actually led to someone in the team, so a pharmacist, saying, actually, no, I want this responsibility. I want to look at this. It fits well with kind of what I'm wanting to do. And then that was sustainable after I left, because it was someone that was working there longer term. They were interested and motivated to make change happen.
And I think, following on from that, allowing yourself a longer kind of iterative phase where you allow things to fail and change them a little bit. And that's what I've kind of taken from implementation is you can have a plan, but you have to be very ready to change that when you come up against things. And I think in the time pressures that we have, perhaps as junior doctors, we often don't allow our plans to change enough because we're under some time pressure to get some results quickly. But that's actually a really important part of doing things.
I think that's where we're at with implementation research. The old school sort of approach to evidence-based practice and research was, it's got to be a linear set out process. How you collect data is decided before you start, and you stick to that. It's quite rigid. But the nature of reality of these systems of where we're implementing is so complex and ever changing that we need to change how we do research. And so, yeah, it has to be iterative. It has to be a two-way between the people in the research team. And I think it has to be rapid, responsive, and relevant. I'm just very, very grateful for your time.
No, it's been really good, thank you.
Thank you.
And
Yeah,
it's really made me think, and I've got to take home. Sound like I'm on the FLP again, don't I, Lizzie? I've got to take home. I am going to be braver. Like, listening to the things I've said, I've noticed I've said fear quite a lot, and the NHS is fearful, and you need to be brave to make change. And after this and thinking about this, I'm going to go away and I'm going to be braver.
That's brilliant. All right, I'll see you later.
Very good.
Thanks very much, Christian.
See ya.
Thanks, everyone.
Bye.
Thanks, bye.